Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with Dr. Eric Weiner. Yale Cancer Answers features conversations with oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about the care of patients with complex brain tumors with Dr. Jennifer Moliterno. Dr. Moliterno is Chief of Neurosurgical Oncology at the Yale School of Medicine. Here's Dr. Weiner.
Before we get going talking about brain tumors and the kind of work you do, could you just tell us a little bit about you, 30 seconds of where you're from and how you came to do what you do?
I'm originally from New York, from Long Island, and went to medical school and then trained in neurosurgery here at Yale. I went for a clinical fellowship in brain tumor surgery or neurosurgical oncology at Memorial Sloan Kettering. And then I returned back here to practice. And I've been here ever since and primarily focused on taking care of patients with brain tumors.
And what motivated you as you were in training to opt for a career focused on the treatment of brain tumors? It's not an easy job.
It's not an easy job, as I'm sure you know from your own job. It's hard, and it's physically demanding. It's emotionally demanding. Taking care of sick people, and I think that was what always attracted me. I had always been interested in surgery. Thought I was going to primarily focus on cardiac surgery, but found that to be boring. So I switched gears to neurosurgery. And I love the fact that I can know where the person's problem was, based on whatever neurological issue they were having. We could just pinpoint it based on clinical exam, and really truly a clinical, field in that regard. And so then fell in love with neuroanatomy and then focused on neurosurgery. And then I was always drawn to the more critically ill neurosurgical patients, and brain tumor patients certainly can be. And what I also appreciated about that patient population was the ability to really impact them and their lives and their family at a time where they really need someone like me the most.
And maybe you've partially explained this already, but what drew you to take care of these such sick patients?
I think just one aspect from a medical perspective is taking care of them when they truly need help, when they truly need somebody to step in and perform a surgery and help them. And then the other aspect is to help to emotionally support them. And so for my patients, it's quite overwhelming and challenging, because not only do they face the potential diagnosis of a brain tumor or brain cancer, but they also have to undergo brain surgery. And so both is quite a bit. And I just think that it allows me an opportunity to not only help them from a technical standpoint, but also to support them from an emotional standpoint.
I often say, and this is about taking care of individuals with cancer in general, not even specifically about brain tumors, that when, as an oncologist, you meet a patient with cancer, that you're given the opportunity to walk into a door into their lives. And not that everyone chooses to enter, but that if you do, it's a pretty rich experience. And I can only guess that that's even magnified when we're talking about brain tumors.
It really is, and exactly how you describe, and again, just being there for someone when they're the most scared in their life, and knowing that in whatever way you can just help them get through it and help their family get through it.
So tell us a little bit about your area of expertise and the types of patients that you typically see.
So I focus mostly on primary brain tumors, and those are brain tumors that originate from the brain or the skull base. And so types of tumors that are included are gliomas, as we call them, from originating from the brain themselves, versus meningiomas from the covering of the brain, schwannomas originating from the nerves. And so all sorts of different types of primary brain tumors, but ones that originate and localize within the head versus metastasize from the body to the brain.
And as people know, cancers do sometimes spread to the brain. One of the curious things that I've always found is that tumors that start in the brain pretty rarely spread any place other than the brain. They don't spread to the lungs or to the liver or to
Correct.
other places that many tumors spread to. Is that right?
That is right. Yeah. The majority, the vast majority of these tumors do not. And rarely, very, very, very rarely, if ever, do we see that a primary brain tumor, one that originates in the brain, or the covering of the brain or the nerves and such, will metastasize outside. So we deal with things a little bit different than cancer in the body with regards to metastasizing to the brain.
And when we think about if there can be such a thing as a simple brain tumor versus a complicated or complex brain tumor, how would you draw those distinctions? Is a meningioma, for example, a simple brain tumor?
So it's interesting because it's not so much the type of tumor, but the other factors of the tumor that really define it as a simple or complex. So I am fortunate in that with my practice that I've established, with my expertise and my experience, I receive a lot of referrals from other neurosurgeons in the community. So my practice becomes more skewed with a complex brain tumor practice. And what that really looks like are tumors that are involving functional brain. So tumors that are located in or around the motor or language areas or areas of the brain that have, a very important function. Or a tumor that's located along the brainstem, such as the one that I did this morning, that's intimately associated with all of the little but very, very important nerves that originate from the brainstem and have functions such as swallowing or smiling or even breathing when regards to the brainstem, as well as other tumors that are located along the skull base that are also intimately associated with really critical arteries and that, are intertwined with the arteries.
So it's much more where it's located than the actual type of the cancer that at least makes the surgery particularly complicated.
Yeah, I think that's a good way to put it. Exactly right. It could just be with regards to the function of the brain or the neurovascular structures that it's involved with versus, just a very deep location, in the middle of the brain that is just difficult to access and, several centimeters within the head, which, transversing various corridors to get there that we need to use to avoid causing permanent damage with regards to the brain itself.
So cancer surgeons who operate on other parts of the body often want wide margins. They want to make sure that there's an area of normal tissue and sometimes a fairly significant area of normal tissue around the tumor to make sure that everything has clearly been removed. From what you're describing, it doesn't sound like there's the opportunity to take a wide margin. You're trying to get as close to the normal brain tissue as possible. Is that right?
For certain types of tumors, yes. For other types of tumors, we do strive, similar to the body surgeons, to get a wide margin. So,
and that depends on where it is?
Correct. And so we talk oftentimes about supramaximal extent of resection for certain primary tumors, such as gliomas or glioblastoma. And so when those tumors are in the right frontal lobe, for instance, which is a very quiet part of anyone's brain, we can really get around the tumor and we can get a nice wide margin. Having said that, there's always microscopic disease, even when we do achieve that supramaximal extent of resection. And so we then still rely on radiation and chemotherapy in those circumstances. For tumors that are in or around the language area, our margin is smaller, of course. And so, for instance, I perform a wake craniotomy, which allows me to really pinpoint that area and to remove that area that is the tumor, that is the cancer, but preserve the functional brain that's surrounding the tumor.
So when you're performing a craniotomy, that is brain surgery, where you've opened up the brain and somebody's awake, you're asking them to do certain things so you can see what's working and what isn't working?
Yeah. And so I'm not doing that. I have a whole team of people. I have a whole team of people for all my surgeries, but for the awake craniotomies in particular, we have an even more specialized team of neurophysiologists. And so thankfully, we have a really beautiful way of doing these cases with neuroanesthesia where the patients are incredibly comfortable during the initial part where we do have to open the skull. And they're asleep and comfortable and no pain. And then we wake the patient up. And depending on what the tasks are, for instance, one that I did last week was a patient who had a tumor that was in and around a lot of higher level functioning. So not just language, but math and reading and writing and interpreting. And that person in particular was a very high level, high functioning data analyst. So those things were really important. So when we woke him up, we had him do all these various sorts of tests that were really, really more in depth than just, move your arm or answer this question. So we can tailor what the tasks are based on the location that I'm working in to make sure that we preserve that function. And so we did that with him. And then once I removed the tumor, we put the patient back to sleep and reattach the skull as we usually do with some titanium plates and screws, and then close the skin.
So I have to say, this never occurred to me that you would have other people in the OR who are instructing the patient or asking them math problems or other such things.
I'm focused on operating.
No. And in my totally naive way, I assume that, you're there operating and you're saying, Mr. Jones, can you move your left leg? But it of course makes no sense. Oh my goodness. And
no, but I'll interject, or I talk to them, I tell them they're doing well, but I have people who focus on that so I can focus on the brain surgery. But of course I hear it, it's in a microphone. And so that way I can tell if errors are being made, and if they're being made, then I have to pull back.
And just one quick question before we take a break. When people are woken up and then you talk to them 3 days later, do they remember it?
Yeah, some people do, some people don't. I think most people do. And I have to say, I've never had anyone that has had a bad recollection. It's a lot that goes into choosing patients for awake surgery is, of course, what I need to be able to do safely, but also choosing the appropriate person to perform awake surgery on is really important. And that goes into a lot of the process of the evaluation and workup.
Sure. So we're going to take just a brief break. This is Eric Weiner with Yale Cancer Answers and my guest, Dr. Jennifer Moliterno, a brain surgeon. And we'll be right back.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where their endocrine cancers program is one of the largest multidisciplinary programs in the country and is experienced in treating rare cancers. More at smilowcancerhospital.org. Over 230,000 Americans will be diagnosed with lung cancer this year, and in Connecticut alone there will be over 2,700 new cases. More than 85% of lung cancer diagnoses are related to smoking, and quitting even after decades of use can significantly reduce your risk of developing lung cancer. Each day, patients with lung cancer are surviving thanks to increased access to advanced therapies and specialized care. New treatment options and surgical techniques are giving lung cancer survivors more hope than they have ever had before. Clinical trials are currently underway at federally designated comprehensive cancer centers, such as the BATTLE-2 trial at Yale Cancer Center and Smilow Cancer Hospital, to learn if a drug or combination of drugs based on personal biomarkers can help to control non-small cell lung cancer. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
This is Eric Weiner again with Yale Cancer Answers. I'm here with my guest, Dr. Jennifer Moliterno, a neurosurgeon who focuses on the treatment of brain tumors. Let me just get a few sort of facts and figures from you. How common are brain tumors?
Patients always ask that question, and I always respond with the truth. For me, everyone who I see and know has a brain tumor, because I do this so much. But in the grand scheme of things, they're not all that common. I think that they've become a little bit more common as the access to imaging has been better. And so people are getting more scans. So maybe some incidental tumors are getting picked up a bit more. But, relatively speaking, I don't think that they're as common, certainly, as other types of tumors and cancer.
There have, however, been a number of high-profile individuals very much in the public eye who have had brain tumors. Do you think that's raised awareness in a way that's potentially good in terms of leading to more funding or other advocacy?
Yes, for sure. Funding is so sorely needed. And for some of these tumors, such as glioblastoma, and of course, Ted Kennedy and John McCain, those individuals who have had those tumors, unfortunately, I do think that has helped. However, that disease is such a challenging disease to treat, and I think that more funding and more work is needed. There's other types of tumors, such as meningioma, that can, in some aspects, at some times, be almost as devastating as glioblastoma, but the research funding for those types of tumors, because they're normally thought to be more benign, is not as great. And so I think that, more awareness there is certainly really important.
And since we've now touched on meningiomas a couple of times, can you describe for the listeners what a meningioma is and the tissue that it arises from? Because they are a little different from what people often think of as more standard brain tumors.
Mm-hmm. And so these are tumors that originate from the covering of the brain, and so the meninges. And so that can be kind of on the top of your head, on the outside, what we call a convexity meningioma, or the meninges, or the covering of the brain, is also along the base of people's heads and skulls. And so they can also be what we call skull-based tumors. And so those tumors can arise almost, behind the eye, or again, pushing on the brainstem, or close to the inner ear. So they can really originate anywhere. And just as you said, they're actually not brain tumors. They push on the brain, but they arise from the outside of the brain, so to speak, but inside of the head.
And do they tend to spread almost like a coating on the brain?
Sometimes, mostly not usually, not really. And so these have been a fascinating tumor, especially for us and for me to understand from a scientific perspective, because they were really thought to be benign tumors, slow-growing benign tumors. And the vast majority of them are, and they're WHO grade 1. But there's a subset that can behave more atypical, and they can really be nasty, and they can spread a little bit more like what you're describing. They can invade into the brain and pose problems. They can cause swelling in the brain, like actually one of the ones I'm taking out tomorrow. And so they can be more problematic. And the problem and issue is I found a lot of patients who in the community will be diagnosed with these, and then, they're reassured either by the neurosurgeon or by another doctor, oh, this is benign, don't worry about it. And then, they might be removed and then they come back with a vengeance, and people I don't think are necessarily prepared for that. And we do understand from the genetic testing that we do on these tumors, that sometimes they do behave more aggressively when you might otherwise think that they're not going to.
So you've raised the question about genetic testing, and here I think we're talking about testing of the tumor itself.
Correct, yes.
Yeah. And how is genetic testing or tumor profiling important for individuals who have brain tumors?
It's so important. I mean, just like it is in your area and every area of cancer, but particularly with brain and even for tumors such as meningioma, where again, I think they were once thought to be more of a homogeneous type of tumor. They're benign, don't worry about it, sort of a thing. They're more heterogeneous. They're not as heterogeneous, genomically speaking, or mutational profile wise as the glioblastomas or some of the other glioma tumors. But they're enough that they can behave a little bit differently, each one from the next. And so for us, we're fortunate in that every tumor that I remove or even biopsy, every tumor undergoes what we call whole exome sequencing, which is just next generation sequencing, which is a fancy way of saying we understand the mutations that are causing the tumor to drive and to form and grow. And so we can then perform the surgery, which again tends to require more sophisticated microsurgical techniques to remove it in these more complex cases. But then we can follow that up with really understanding the genetic mutations of the tumor and then personalizing our treatment towards more precisely targeting it and treating the tumor and the patient.
With medicines?
With medicine, sometimes it also can influence radiation as well. So, for instance, with glioblastoma, it's a very standard approach. All the patients will undergo surgery for maximal resection and then follow that with radiation and a certain chemotherapy. For meningioma, there's really no good systemic therapy. And so oftentimes we'll then decide when and whether to use radiotherapy. And we here in particular will help guide that decision making by using the genetic testing to tell us when to radiate.
Got it. Now, I think most people know that the treatment of brain tumors is often quite challenging and that drug therapy is not quite as effective in brain tumors as it is in other situations. And there are two different types of explanations that I've heard. One relates to what's called the blood-brain barrier, which perhaps you can talk about and comment on whether it's important or not. And then the other relates to the microenvironment, or what some might think of as the soil in which the brain tumor is arising. Do you mind commenting about those two different concepts?
You're absolutely right. And, so the brain is very privileged, and so it is protected, and the way that it's protected by this blood-brain barrier. So that allows the brain to keep bad stuff away. And so, as chemotherapies and systemic therapies are bad stuff, oftentimes that we rely on to treat. And so the brain's response is to keep those things away. And unfortunately, that can make it difficult for the drugs to get to the tumor or to get to the resection cavity or to get to the brain itself. There's been all sorts of things that various people have done to try to help penetrate through the blood-brain barrier, even, opening it with medications and intraarterial or, directly implanting things and drugs directly into the brain. It's just been such a challenge to do so. And I would say in large regard, it has not really pushed the needle all that much. And here we're talking more so in terms of the interaxial or the tumors that originate in the brain, such as gliomas and glioblastomas, less so the meningiomas. But even with meningiomas, there's really no good systemic therapy. There's no standard of care for that. So again, we rely mostly on surgery and maximal resection that's safe, as well as radiotherapy.
And do you think that the microenvironment in the brain is somehow fundamentally different than in other tissues and makes it more difficult to treat these tumors?
Absolutely. And I think that then again goes back to the brain just being different and unique and special and privileged. And that certainly, I think that certainly helps, of course, most people. But it does pose a big challenge for the treatment of brain tumors.
And for our listeners, when we refer to the microenvironment, we're talking about the surrounding tissue in the brain, and that the surrounding tissue in the brain may, for whatever reasons, be different and make it more difficult to treat these cancers than the surrounding tissue, for example, of a breast cancer. We've talked about radiation. We've talked about systemic therapy and specifically chemotherapy. Who else is on this your team? Not necessarily the team in the OR, since I don't think that the medical oncologist or neuro-oncologist who gives chemotherapy or the radiation oncologist is necessarily there in the OR with you most of the time. But they are your team members. Is that right?
Absolutely. You know, it's a huge team. It's a huge team in the OR, as we had discussed a little bit before, and I rely so much on everybody around me. You know, from the nurses in the room, from the scrub techs, from the neurophysiologist, neuroanesthesiologist, you know, the MRI techs in the operating room, you know, you name it, everybody plays a huge role in the patient surgery and care. And then, like I said, for most tumors, brain tumors, it's not just the surgery, it's beyond the surgery. And so my teammates outside of the OR are the neuro-oncologists, the radiation oncologists, the neuropathologist, the neuroradiologists, you know, and those doctors and providers, and also the nurses and the APPs and the assistants and everybody, the fellows, et cetera. And so a lot of times what we'll do is bring patients to our multidisciplinary tumor board, which I'm fortunate to lead here, as well as the precision brain tumor board. And we discuss patients, so we're all on the same page. We have a plan. Sometimes it's incredibly clear cut, and we don't need to do that. We all know, you know, what needs to be done. But other times it really does take a balance, you know, because there's risks and benefits to everything, pros and cons to everything. And we always want to do the best and the right thing for the patient. And so it's a group effort for sure.
Dr. Jennifer Moliterno is Chief of Neurosurgical Oncology at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.